There are some of you in this room who have heard me speak ad nauseum about what I'm going to speak about right now. And to those of you who have suffered through this before, I apologize. But there are lots of new people who are new to this, and so I'm going to more or less start from the beginning and give you an overview of a project that I and Paul Freeman have been working on for 10 years, and we're very excited about it, and we never would have believed it would have taken this long to do what we've done, but we're on the right process, on the right path, and there's going to be some very exciting things that will come out of it and already have come out of it. But this is a review of the effectiveness of community-based primary health care in improving both child and maternal health that I'm going to be speaking about now. And I'm going to give an overview about the introduction and how we got involved in this and what we did and some of our findings and what some of the broader implications are. And there are a lot of overlaps between what I'm going to share with what Susan shared. And these are very deep and complex topics, and it's a real challenge to present a lot of information in a short period of time. But let me start out by saying that over my professional career, early on I recognized that community-based approaches to improving the health of populations, particularly the health of mothers and children, was very powerful. But it was really receiving very limited attention by people of influence, organizations, even research. And I had the great privilege early in my experience of being exposed to some very outstanding and pioneers in the field of community-based primary health care and community health. And one of them just walked in the door here, Gretchen Berggren. Gretchen, please stand up. So my life was forever changed. My life was forever changed when I visited the Hospital Albert Schweitzer in Deschapelle, Haiti in 1979. Gretchen Berggren was not there, but the work that she and her husband left behind was there. And the community-based primary health care program that they developed there, I immediately recognized as something incredibly powerful. And that led to my following up on that, and I got to know Gretchen and Warren. I was living in Maine at the time, and they were in Boston. I got to know Warren and Gretchen. And through Warren and Gretchen, I got to know Dr. John Wyan, who I mentioned just a minute ago, who became a mentor for me in my early work in Bolivia that David Shanklin became involved with later. And through those associations, in our engagement, thinking about how we can bring a stronger voice to community health and community-based primary health care, and also recognizing the incredibly important early foundational work in this field that Gretchen and her husband were part of, as well as John Wyan, and you heard the name Carl Taylor already, who founded the Department of International Health at Johns Hopkins in the 1960s, who himself had been a medical missionary in North India working with John Wyan and was a pioneer in community health and primary health care, who all of these people were both field workers and academics. So Susan mentioned that very unfortunate circumstance today where we have so few people who have an academic bent, who have really been up to their elbows in field work and trying to think about how to demonstrate the effectiveness of that. But these were people who had that background and saw the potential and the vision of what community health and primary health care could be in terms of improving the lives of people, and committed themselves to the rigor of collecting data and publishing it to show that they in fact could be effective. These were small-scale studies, but this is an enormous challenge to do this kind of work. And so when this working group was established almost 20 years ago now, some of us were increasingly concerned but very excited about the growing amount of evidence of the effectiveness of these approaches for improving the health of people. And Paul and I decided that we needed to do a literature review and pull together the evidence about how effective community-based approaches can be in improving the health of people. And so we started talking about this, and we formed a working group, a committee within this working group that started to take this seriously about how we might go about doing this. And so 10 years ago now, we had a small committee that Paul and I headed. We started looking for some money, and we started looking for volunteers, and we started conceptualizing what we might do. And you see here that we put a lot of effort into trying to find a little bit of money to support this. That took an enormous effort to find $10,000 to carry out the first steps of this. The World Health Organization, after months of discussion and negotiation, we finally got $10,000. And we also decided early on that if we were going to do this, it'd be great to have an expert panel to bring some authority and some dignity to this. And so we recruited an expert panel of world-class people who were interested in community health and had a strong record in it, either the field work side or the academic side or working with international organizations. And so with just basically no money but some volunteers that surfaced through our own connections within this working group, we developed a procedure for thinking about how to collect data for this under the auspices of a expert panel. So we had, in addition to Paul and me, two other people, Bahia Razik and Sandeep Gupta, and the four of us worked very hard on setting up a procedure, a protocol. We thought we would start out primarily focusing on studies that had demonstrated impact on mortality, but the expert panel wanted us to expand that, and so we ended up with an approach in which we looked for evidence of effectiveness of community-based approaches that involved improvements in the coverage of evidence-based interventions that we knew had an impact on the health of children. We started out just with children because our initial $10,000 grant was from the World Health Organization, and they wanted it to be focused on children, so we started out with that. So we looked for any evidence that we could find in which there had been improvement in the population coverage of an evidence-based intervention, improvement in nutritional status, serious morbidity or mortality, and a geographically defined population through a project, a program, or a study that was community-based. And by that we meant there were activities that took place in the community outside of a physical health facility, a health center, although we did recognize that village health posts aren't really health facilities as we think of, but they're a community-based effort. And so we developed a data extraction form, and we had two people extract data for that report of an assessment, and we had a third person who resolved any inconsistencies in those two data extractions, and then we put that in an electronic database. We made a real effort to identify evidence that was not in a peer-reviewed journal. If it was in a book, and particularly the Jomked book, which is so famous, we certainly drew on that as one of our data sources. We had other books that weren't in the peer-reviewed journal article literature, and we had a lot of project evaluations that had been carried out by various organizations. A number of these were funded by the USAID Child Survival and Health Grants Program. So we were trying to ask the following questions. How strong is the evidence that community-based approaches can improve the health of children? I mentioned we started out with children, but only in the last couple of years we got a small grant from the Gates Foundation that enabled us to expand this to mothers as well as children. What specific community-based activities are affected? What are the conditions that facilitate effectiveness? What characteristics do effective CBPHC activities share? How strong is the evidence that partnerships between communities and health systems are required in order to improve child and maternal health? And how strong is the evidence that community-based primary health care can promote equity? So as we got into this, we had a lot of support from the American Public Health Association. We had no money, a lot of volunteers. This was a volunteer effort that grew out of this working group. After we had been involved in it for a couple of years, all of a sudden UNICEF got interested in what we were doing. They said, well, this is great, and we want you to present our results in, I think it was 6 weeks, right, Paul? And all of a sudden, the high-level people at UNICEF were interested. We got involved with them. Other organizations, we had people from the World Bank and USAID on our expert panel. During that early time, I was working at Future Generations, a small NGO, and I was the Carl Taylor Professor for Equity and Empowerment. And I worked with Dan Westner at that time, who's sitting here joining us today. And I had a lot of time to work on this because Carl Taylor and Daniel Taylor knew this was important, and so I was able to really move this forward. Even though we didn't have any money, I had an endowed professorship, and so that enabled me to put time into this. But the problem we got into was that we kept finding more and more evidence that needed to be in our review. And so we kept having difficulty bringing this to a completion, and then people got tired of giving us money, even though it was very small amounts of money. We couldn't get it finished. It was a very tough situation that I found myself in, and other people, Paul's been very frustrated with this because it's taken so long to finish it, but we've been working on it slowly. And so after all this time, we have pretty much come to the completion of this long journey. We have a journal supplement which we had hoped to share with you today, but unfortunately it still hadn't quite come out the other end yet. It seemed like a never-ending process. But we do have a journal supplement that is nearly completed for submission to the Journal of Global Health, which is one of the outstanding journals now in global health, and they have agreed to publish this. We're still working on some of the peer-reviewed elements of this. And Dr. Carl Taylor was the original chair of the expert panel for this, and he died in 2010. And so Dr. Robert Black, who was a professor of international health at Johns Hopkins, who has been on the committee from the beginning, is chairing that now. And so they will be writing a summary piece and a recommendation piece that will be the final article in this journal supplement. We have already produced some important documents. You can see this one was a report we produced in 2009 that's on the internet you can download, which was an interim report before we finished everything. We've written a report about strategies used by effective programs, which was widely publicized by USAID. Paul Freeman was the first author on this article that was published in 2012. But as we have continued this, we've had more than 150 people involved in this as reviewers and volunteers in one form or another. Quite a few students at Hopkins more recently have become engaged in this. And this is the way I felt during a long part of this 10-year process of trying to deal with this massive project and very few resources to deal with it. But I felt like I just couldn't let go of this because I thought it was so important. And I felt when I read this Vietnamese proverb, I said, I think I can identify with that because I've been writing on the back of a tiger and just couldn't let go of this. So in the process of all of this, over a 10-year period, we've reviewed 10,000 documents. These are just the PubMed references. We didn't have the energy or the resources to explore all the other databases out there. And we've included a lot of other references I mentioned that aren't in PubMed, but we have ended up with 549 articles on child health and 153 articles on maternal health for a total of 702 that make up our database. There is some overlap because some assessments were assessing maternal health as well as child health. So just a few comments about some of the findings here, and obviously time goes by quickly, and this is a vast area. But in terms of the maternal health review of our 153 studies, we can see that there are three categories in which community-based approaches can improve maternal health through a reduction of medical complications during pregnancy, provision of routine maternity care, development of community capacity to promote maternal health, and refer obstetric emergencies. And we had three main outcomes that formed the maternal health component of the study. These are some examples of community-based strategies that we know are important for improving maternal health that are well known, but certainly surfaced in our own study, but also some of the community-based strategies by which these interventions were shown to be effective in the assessments that were included in our review. And I'll be referring to some of these approaches again in a minute. In terms of neonatal health, there are very exciting interventions that have been developed and implemented at the community level and rigorously evaluated for their effectiveness. One of the overriding themes of all of this work for the past few decades has been a focus on specific interventions rather than how all of these can be brought together into a package to achieve a long-term, sustainable, and effective program. And so we've had to deal with this sort of dualism, in a sense, in the process of all these reviews, because some are very narrowly defined, discrete, highly technical interventions, and others are very broadly based community primary health care projects. But you can see, obviously, some of the interventions here that are terribly important for improving neonatal health through community-based approaches. Home-based neonatal care is one of the great advances in global health in the last decade or so, all arising from research at the NGO level, particularly by Search, a small NGO in India that I'll be mentioning more in a minute, but with strong evidence of effectiveness that has been confirmed by subsequent randomized controlled trials as an example of where RCTs have been able to be used to confirm the effectiveness of community-based approaches. Many of you know about child health interventions that can be implemented at the community level that have been shown to improve the health of children, defined in the ways I mentioned before. I won't go into all of these at this point, of course, but they're certainly well represented in our study, and these additional ones as well. So we have all of these interventions that we know can be effective, and then the question is, how can we get all these together into a package, into a program that can be practically and realistically implemented within the constraints of what exists at the field level? That's certainly one of the overarching themes in all of this. But one of the exciting things for me that came out of this was that if you look at all of the various studies that have been done, the assessments that have been done of programs, and the ways in which programs have implemented interventions that have been effective in showing improvements in health, you can boil it down to 4 different strategies, and they're not mutually exclusive. They can go on at the same time with other ones, but it involves home visitation, community-based treatment by community health workers, outreach from health facilities by mobile teams, and then participatory women's groups. And they all have various specific ways of implementing that they can be implemented at the local level depending on all kinds of circumstances. Now, we looked through our 702 articles for any evidence about the equity of the programs that carried out community-based primary health care interventions. And we found 52 assessments in the child health portion of our study, and overwhelming evidence that community-based approaches are not only equitable, but they're what we call pro-equitable because they have a more favorable effect for the more marginalized, disenfranchised portions of the population than for the other part of the population. And this hasn't been pulled together in this way that we've seen in the literature yet, so we think this is going to be an important contribution. One of the sub-themes in all of this is, although it's not explicitly stated in what we write, but it's implicit, and that is that there's very little evidence that facilities have any of these kinds of effects when you look at the effect of investments in a facility and its effect on the health of a population of people. And there's a lot of evidence that utilization of facilities is highly inequitable. And by that I mean that the people who need the services the most are the ones least likely to use a health facility. And so the pro-equity component of community-based primary health care is terribly important, I think. And it's so obvious that community-based primary health care programs do achieve these effects because they're reaching out to every household in most cases, and the households that are furthest away and most difficult to reach, that have the poorest and least educated people, are the ones who are the least likely to utilize the facility. So we spend a lot of, one of the things that makes our review important, I think, is we put a lot of energy into trying to understand the strategies that were used by programs to achieve their effectiveness. And in the global health academic sphere, and even in the funding and programmatic sphere, so much has been focused on the intervention itself without really putting sufficient attention on how those interventions can actually reach the people who need them. And this is a quote I read back in 1980 that still is a very powerful quote for me, and it fits so nicely into the whole mantra of community-based primary health care. And I won't read it out loud, but I'll encourage you to just take a minute to read that quote there at the bottom of the slide. And the whole description of strategies used is very underrepresented in the literature. There's usually in an article there'll be a few sentences about how a program or study was implemented, but there's so much detail that goes into how a program is implemented that it just doesn't get reflected in the literature, unfortunately. So this is an example of some of the forms of community collaboration that we observed in all the 702 assessments that we had in our review that are written up as one of the articles in our journal supplement. That again, I won't go into all the details of this, but there's a whole richness of how communities can engage with health programs. And as Susan mentioned, which I couldn't agree more, you know, the people working in public health and ministries of health particularly don't have the kind of mindset that it takes to work effectively with communities, unfortunately, and there are all kinds of reasons for that. But the NGO world has been much more dynamic and effective in developing creative ways to work meaningfully in partnerships with communities. So a lot of our evidence that we draw on is from the NGO community more than from the large-scale Ministry of Health literature, of which there's not a lot. Community involvement with the planning, implementation, and evaluation of programs in our studies, you know, it was pretty good. It wasn't great, but there was a lot of community engagement based on the interpretation of the reviewers of these studies. I mentioned these four approaches to implementing interventions, the intervention delivery strategy, which is important. And then another piece of all of these assessments that became important for achieving effectiveness was strengthening the health system as well as working on community-based delivery. So there's all kinds of elements in which some engagement with the health system at a higher level is terribly important. And so we found all of these were commonly used by programs and projects. So we developed this little framework, which I'm very fond of, and in fact, I have to give credit to Bob Black for developing this on the back of of a napkin one day when we had a meeting in 2008 at UNICEF. But it's so simple. But it builds on what Susan was saying, I think. And that is, what it's really saying here is that if you don't have community empowerment, the ability of a health system to really achieve the kind of outcomes that it can potentially achieve is going to be very limited. And so we put in here these 4 delivery strategies that came out of our review: home visitation, participatory awareness groups, community case management, and outreach services by mobile teams, as ways in which communities can be engaged to help interventions reach those who need them and to achieve the kind of potential effect that we know can be carried out. One of my most favorite examples of recent literature that really reflect all of these issues that I'm talking about is a study by Ari Johnson and his colleagues from Mali, which was published a few years ago. And they used all of these strategies that we've already identified from other studies as well. Their study was not a big, it didn't reach a big population, but they developed these various strategies here. And they demonstrated a dramatic decline in under 5 mortality. So you see this dark line here. This is their project in Mali and the tremendous decline of under 5 mortality they achieved through these approaches compared to the long-term secular trends going on in Mali and various places. We have an article in our journal supplement on the programs that had the longest term impact on mortality reduction that we could find that was in our database. We queried our database for projects, programs, or studies in which there was evidence for 10 years or more of mortality impact. And interestingly enough, we ended up with 4 projects, programs. One of them is the program that Warren and Gretchen Bergman started at the Hospital Albert Schweitzer in Haiti that I visited. The first one on the left there you see is the Maternal program at the International Center for Diarrheal Disease Research. One of them is the John Kidd Project, which Connie Gates has been working with for decades. And then the other one is Search in India that I mentioned a minute ago that did the pioneering work on home-based neonatal care. They have these common characteristics which I think are terribly important. And I think another thing that's important to say is that all of these projects have intellectual and personal roots that go back to Carl Taylor and John Wine. The Maternal work was heavily influenced by Carl Taylor's early work in India. The Hospital Albert Schweitzer work that the Bergens did was heavily influenced by John Wine, who was their mentor. The John Kidd Project was heavily influenced by Carl Taylor, by Roger de Villaroli, and the Search program in India was also heavily influenced by Carl Taylor as the mentor of all these people. So you see these common characteristics that these 4 programs have. And I think there's a lot of meaningful evidence here that we can build on for the future. And I think my time is up. So I'm just about finished here. So let me just, I can say more about the broader implications of all of this, but I think this is an important slide and then I'll quit. This is an article from The Lancet that was published last spring. And it's messages from the new Disease Control Priorities volume on maternal and child health. And Bob Black, again, is the senior author on this. And using the LiveSave tool, which is a little different approach to all of this, but using the LiveSave tool where they look at the known efficacy of interventions and their potential of saving lives, if these interventions were applied at high coverage levels at scale, how many lives could be saved. And what they show is that through community approaches on the far left, maternal and child health interventions could save 2.4 million lives every year. as opposed to what would be saved by interventions only at the primary health care facility level or the hospital level. And it gives, I think, a very powerful message about why we need to be investing in community-based primary health care. And I think our review will also provide supportive evidence, and it's an important time to be making these statements because we're starting another 15-year period for ending preventable child and maternal deaths, and we're entering the era of universal coverage and how to achieve that. So I think every important message that we can put forward there about why we need to invest more in these approaches is needed right now. Sorry to run over.